Interventional Musculoskeletal Ultrasound. Conflicts of interest. I'm a stockholder with Sonics, which is a company that makes the device you see at the bottom of the screen, and co-editor of a textbook for ultrasound for orthopedic surgeons. The first illustrative case is that of a foreign body in the region of the elbow. We will use the ultrasound to assess where that foreign body is, and then look at the tissue damage, vessel damage, and plan our approach, and use the ultrasound to perform a biplanar guidance of our instruments. Here we see an x-ray of this young man with this metallic object in the area of his elbow, and his history is somewhat vague. He really didn't come forward, which probably means that he was doing something he ought not to. On the screen at the bottom or distal end, you can see a third-degree burn, but without skin penetration. Then in the middle, you see the entrance wound, and the upper arrow indicates where the foreign body is. On his physical exam, the radial sensory is out, but the motor function is intact, although some muscles are painful to use. So our questions were, can the foreign body be removed by a direct incision over it, and what other damage has taken place? Is it close to the skin? Well, what about doing a tomogram? So with our linear probe, we can perform a tomogram. The metallic object is indicated by the two arrows, and we can see that it is entirely deep to brachioradialis and is in fact in the radial wrist extensors. And we can see the blood vessel draped over the top of it. So it didn't seem advisable to go directly down to pull out the metal. The presence of the artery and two veins can be confirmed by going to the long axis of the forearm. And while we're talking about vessels, how about doing an angiogram? So by switching to color flow or the other Doppler, we can assess the blood vessels, at least those that are on the proximal side of the metal. It would be possible for there to be a blood vessel that was damaged deep to the metal, and the metal just blocks our sound. So how are we going to remove the foreign body? With X-ray, we use biplanar localization. It involves moving the X-ray equipment or the patient's limb. Ultrasound allows the use of two rigidly orthogonal planes, which are attached, as it were, to the end of the probe, but these planes are placed arbitrarily to meet the needs of the surgical team, and nothing needs to be moved except for the probe. Here we're going to draw a line by using the linear probe from the entry wound to the object, and then with a light toggle we can choose our position of where, and this would be the two planes. Here you can see in the upper left and the lower half of the screen the architecture of normal muscle, but the foreign body coming in has sort of ground things up, and so we just have this neutral gray stripe in line with the arrow. We can use that same localization with the tendon grasper and bring it in toward the object, and then as we grab it, notice the object becomes brighter because the grasper holds it perpendicular to the beam. And we can follow it as it comes out of the wound, and it turns out it's the back end of a shotgun shell. And then we can irrigate or reevaluate our blood vessels. So in summary, we've assessed the position, the damage, the blood vessels, and performed a biplanar guidance of our instruments. Now, what about using this where bony landmarks for arthroscopy have been erased by edema or obesity? Our illustrative case is a person with a Baker cyst, you can see there at the bottom of the screen, and we would like to marsupialize that into the posterior medial compartment, as she's not arthritic enough to warrant a total knee replacement. there's relatively little fat on the front of the knee, and so we can make our usual um, intercondylar approach from the superior lateral or anterolateral portal and have our viewing scope in the posterior medial knee. But our working portal is now going through 3 inches of fat, and so it's hard to be very accurate. So we're going to use the ultrasound to place our portal. On the right, you see the view through a 70-degree scope, so we're actually looking at the back of the medial femoral condyle, and on the left we have ultrasound. Notice we really don't see the back of the condyle because this is not facing the ultrasound probe, whereas we see very well a part of the cyst and the medial surface of the medial femoral condyle. We'd like to make a portal here, which would be about here on ultrasound, and we're going to work here. So what I'm going to show you now, because this is an old video, this is about 10 years old, and you really won't see the needle very well because the machine is old and the approach is very steep. But you'll first see the disruption of the tissue as the needle comes in, and then it'll be too far posterior. So we'll remove the needle, and then you'll see that well. And then we'll pass the needle in again in a more desirable position. So here we go. You can sort of see the disturbance in the fat there as the needle comes in, but it's too far posterior. So we remove it, you see it pretty well, and then we reposition it to be slightly more anterior, and we can follow it as it comes into the knee. Then we can pass a nitinol wire down the needle and use the hip arthroscopy equipment to operate in the back of the knee. Another frequently seen condition is frozen shoulder, and usually the x-rays are unremarkable, the MRI may be unremarkable, but we see fluid collecting around the biceps tendon. So the biceps tendon is not the source here, it's just fluid coming from inside the joint. And then through the back of the shoulder, you can inject the joint with lidocaine and steroid. And if it's early, that may be all you need to do. If it's a few months later, then you have to send them to physical therapy. What about calcium? It's a hard material and is well seen on x-ray. And here on the left is the coracoid, and on the right is the calcium collection in subscapularis. So it's actually an impingement. Now notice your brain is, because of the shadow, you're assembling this idea that this is this big wad of calcium like you saw on the CAT scan. But watch how it changes. So we're going to inject lidocaine into the skin and into the muscle and into the bursa. This will control the pain in everything except for the bone. Thank you for not asking me how I know that. But when you operate in there, try not to touch the bone. And you can see this calcium, we can actually see through it, which means that it is breaking up naturally. And we can place our injection of the bursa. And then we can place an 18-gauge needle into the calcium. We start with the part that you can see through because we're pretty sure that that's going to be soft. And you can flush in and out with saline or lidocaine and get some material out. But notice when we move to the what appears to be solid, see how it completely shadows what's underneath it. But as the needle passes and lidocaine is injected or saline, we start to see it break up a little. It's actually a hard but a thin layer of calcium, not that big chunk that we saw on the CAT scan. And the material collects in your syringe. What about infection? This is a 75-year-old woman who has 2 well-functioning total knees. She develops pain in the shoulder with swelling and redness, and she's going to see her knee surgeon, and so she waits 3 weeks. And he takes one look at it and brings her immediately to the ultrasound room, and we can see bone below, or humerus, and deltoid above, and a layer of mixed material between. And using the ultrasound, we can select the place to put our needle to aspirate some material that we hope will be the most revealing. And it came back Staph aureus, and she was on the table that afternoon after coming to see her knee surgeon in the morning. Your concept of distance will change with the use of ultrasound. By palpation with injection, we think of 2 centimeters as a close distance. With ultrasound, you'll think of 2 millimeters as a short distance. This is a patient who, a lung cancer survivor, but they didn't put her rib cage back together. So you can see the tip of a rib just sticking out there and watch the lung move underneath it. And the scapula doesn't move properly over this. And I was unsuccessful in getting a thoracic surgeon to reconstruct her ribs. So what she has is an injection of the bursa at the tip of the rib. And this is something you wouldn't think of doing blindly. But with ultrasound, you can see right where the needle is going. Assessment of hardware. This is a total hip where the acetabular cup was placed too far anterior. And we know that the acetabular cup is rough metal, and look how it reflects ultrasound at every angle where it's sticking out too far in front of the pelvis. The smooth metal of the neck and the head only reflect where they are facing the beam, but the rough metal can be seen everywhere. How about using ultrasound to observe vessels and plan surgical exposure? This patient has had 2 previous arthroscopies. She has cartilage loss in the lateral compartment. Her surgeon is trying to delay the inevitable total knee. So sent her to me, and this is what the first 2 MRIs looked like. And you can see that there really isn't a lot of cartilage there, but the patellar tendon looks pretty normal. Before coming to me, she got another MRI, and this is what her patellar tendon looked like. It looks sort of like syringomyelia in the spinal cord. But what it is, if we do an ultrasound, is that its structure is fairly normal. It's just filled with edema fluid. So the fibers are running up and down, but all that water in there is why it had that area on the MRI that lit up. So our assumption is that this total tendinosis of the patellar tendon was probably secondary to an ischemic cause, because the surgery that had been done was very nicely done. So we'll find out where is the blood supply for the patellar tendon. And you can see it's coming up the back, the deep surface of the patellar tendon, and lateral. And if you look at the right, this is the recurrent anterior tibial tendon coming up over the tibia, and the lateral inferior genicular artery also feeds this. So those were the 2 arteries that we wanted to protect. So we were probably less aggressive with the fat pad, and we protected the recurrent anterior tib and the lateral inferior genicular artery. But we set the tibial components a couple of millimeters more medial than we usually do. And the lady did very well. And here's what her tendon looks like 2 years later. It still has that massive blood vessel, but it's doing okay. And it's still part of the recurrent anterior tib. Injecting biologics can be done with ultrasound very accurately. to reduce the pain of injection and increase the accuracy of injection. This is a patellar tendinosis. For contrast, in the lower right-hand corner is a more acute tendinosis. This one, interestingly, did not have a lot of blood vessels. Usually they do. In the lower left corner, one can see maybe even a little calcium or little bony fragments off the inferior pole of the patella. And we can look back and forth, sweeping medial and laterally to find out where the maximum damage is. And then we can go short axis, and you can see there in the center is the hypoechoic area coming up onto the patella. And what I've started to do lately, because this is sort of a painful procedure, is to inject lidocaine into the tendon sheath at the upper end near the patella, and some into the fat pad deep. Again, you have to make sure you're not sucking on a blood vessel. And then we can bring in our needle to inject whatever biologic that is that you want to inject. And you can check your needle in short axis as well. And here is the injection. And it's a fairly dense, a healing tendon is a very dense material, and you're not going to get more than a cc or two in that tendon area. Here's an injection of a linear tear in the supraspinatus. Again, we're using ultrasound to guide the PRP right there. This is a patient. These are patients we inject with Botox for thoracic outlet. This would be the P minor or the anterior scalene. This is a young dental hygienist, and you can see the P minor running from the chest on the right to the coracoid on the left. You just don't see the coracoid. And the needle is coming into the pec minor, and you can see we're dodging the pectoral artery. In this patient, these are his scalene muscles, and the reason we're injecting him rather than doing surgery is that he's a scar former, and he's had terrible results with other general surgery or ENT operations done. And so we're trying to avoid doing a first rib resection. And so we're going to inject the anterior scalene with Botox, and this works pretty well for about 5 months. So we're kind of running up and down, looking at branches of the brachial plexus between the two scalene muscles, looking at the internal jugular in the way, and then we're going to come down to where we're just above the rib and put our center line on the anterior scalene. And so you're really not looking at the needle, you're looking at the disturbance created by the needle going into the scalene muscle, and injecting your prescribed Botox there. And he did very well. Thank you for your attention, and look forward to seeing you again on this website and YouTube channel.